Again, we welcome you all to the Scientific Symposium. Today's Scientific Symposium will go through 3 topics followed by panel discussion, and we will take question and answer during panel discussion. We would entertain only written questions. Please reach out to MSD volunteers for the paper slips for your questions. To chair the first topic, I am pleased to welcome Dr. G. Vijay Kumar. Dr. G. Vijay Kumar, consultant diabetologist from Apollo Specialties and Diabetes Medicare Center, Chennai. Dr. G. Vijay Kumar has more than 30 publications in reputed Indian and international journals. He has also chaired and spoken in most of the national and international diabetes forums. I welcome Dr. G. Vijay Kumar to the dais to do the proceedings.
Good evening, and many thanks to MSD, Dr. Biji, Dr. Padmanabhan, and all of you. Sachin. Today I am given the task of chairing a very good session about the dilemma amongst the physicians or the diabetologists who is treating diabetes, because invariably we go for a combination therapy. And in the combination therapy, the must molecule is metformin. And you know, the understanding of diabetes is so good and of late. And then there is a growing concern and the paradigm shift in the management of type 2 diabetes. And we need to choose the right drug as an associated medicine for metformin. See, global guidelines also mentions various drugs after metformin, including the incretin-based therapies. Since we have many options, several options that are there, which are multiple in number, at least about 6 or 7 molecules we have. And it is our duty to check the right choice of combination along with metformin for the right patient at the right time. And today we are assembled here to enlighten us on why not gliptin as a good combination for metformin. To convince us that gliptin is a very good combination along with metformin, we have Dr. Rajiv Kovil, who is a senior consultant in diabetology from Mumbai. Apart from his regular diabetes care, he runs special clinics on prevention of diabetes and foot care clinic. A visiting consultant in several hospitals in Mumbai, published several papers in national and international journals, and is also involved in several clinical trials, and also he is a member as an organizer in many organizations. Dr. Rajiv Kovil.
Thank you, Chairperson, for those kind words. Before I start, I'd like to thank BG and the organizers of this event for a fantastic event in a palace like this hotel. Thank you so much for having me here. Today, I'm going to talk about whether there is a dilemma in choosing drugs after metformin. And I personally don't think there is a dilemma. I'm Dr. Rajiv Kovil from Bombay. I have 2 centers in the western suburbs of Bombay. And I'm going to talk about what after metformin. Most important thing that we need to realize is that type 2 diabetes is a very complex problem, and we should not be glucocentric in our approach. We should be taking the patient's confidence, the patient's, a lot of patient's role in deciding what kind of therapy we choose, because finally after he leaves our cabin, he's going to focus on his lifestyle depending upon the kind of counseling we have given him. So the ADA ESD position statement also says that we should gauge the patient's preferred level of involvement, explore where possible therapeutic choices, utilize decision aids, and there should be a shared decision making. Most importantly, these are guidelines, ADA ESD guidelines. Obviously for a normal weight, underweight, overweight, type 2 diabetic, metformin is the base therapy. After that, you could add a TZD, you could add an SU, you could add a DPP4, you could add a GLP-1, or a basal insulin analog. Now, what happens actually in clinical practice is quite different than what happens according to guidelines. Guidelines only tell us it's not a mandate. As I said, type 2 diabetes is very, very complex. We don't want the patients to call up the next day morning with hypoglycemia. We want our drugs to be durable, to be lasting a long time. We don't want complex dosing. We don't want any of the oral antidiabetic having any CV or renal side effects. We don't want hypoglycemia. We don't want weight gain. And we want a good 24-hour control. So patient requires all this, and that's what he comes to us for. So in this setting, we need to have drugs which can kind of comply with all these things. When I was studying diabetology 2 decades back, there was only beta cell dysfunction. Then came insulin resistance. Now we have 8 pathophysiological defects, and we need to treat all of them. With the help of X-ray crystallography and reverse molecular mimicry, we've been able to identify what are these pathophysiological defects in type 2 diabetics. And nowadays, companies are kind of designing molecules to kind of feature on these defects. The TZDs and the DPP4 inhibitors are prime examples of how we have designer molecules for it. The ADA targets remain the same. We need to have very, very tight glycemic control for all our type 2 diabetics. Unfortunately, 50% of patients across the globe are in poor diabetes control. So why is metformin not enough? Studies tell us that beyond a 1500 milligram of metformin, there is no incremental reduction in HbA1c. On the contrary, the GI side effects go up. And this holds true for every possible molecule. We should add on a molecule before we go on to the maximal dosage of any particular molecule. So never go on to a maximal dose. Add is the dictum in diabetes and not replace. This is the Belfast diet study, which kind of monitored patients who were on diet for a long period of up to a decade. And what it told us is that insulin sensitivity or insulin resistance is a pathophysiological defect which continues all throughout the disorder. It remains the same. While beta cell dysfunction at diagnosis is almost 50%, and it progresses with time. The UKPDS actually confirmed this, saying that diabetes is a progressive beta cell failure. So we need to understand that we need to give molecules which kind of don't worsen this beta cell dysfunction, because that's what is going to make glycemic excursions, and that's what is going to make complications. So insulin resistance is going to remain the same in our patients with type 2 diabetes. So what are the decision points that we have while choosing a drug therapy? Efficacy, hypoglycemia, weight, CV safety, whether it preserves beta cells, compliance of patients, cost, and whether it has a good mechanism of action. Now let's look at efficacy. This was a study published almost 7-8 years back, done on approximately 1,000-odd patients, and was done to assess the efficacy of a combination of sitagliptin plus metformin in patients who are failing to metformin monotherapy. And over a 24-week period, sitagliptin caused a good 2% reduction in HbA1c. These were patients between an HbA1c of 7.5 to 11, and this is what we also see in clinical practice. Most importantly, all these patients tolerated the sitagliptin metformin combination with no desirable or undesirable side effects. In this, there was also an open label study which focused on a HbA1c of more than 11, and that caused almost 2.9% reduction in HbA1c in those patients who had an HbA1c of more than 11. Sitagliptin combination with metformin also caused a decent reduction in FPG and PPG, as you can see on the slide, 3.9 millimoles and 6.5 millimoles in PPG. And in the open labeled arm, it caused 11.6 milligram reduction in fasting plasma glucose. The next step, when metformin fails, what comes onto our mind? This study was specifically done to address that question, whether they assess the efficacy of adding on a DPP4 inhibitor versus an SU when patients are on ongoing metformin therapy. And you have two sets of studies here. The one on the left is a 2-year study versus glipizide, and the one on the right is a 30-week study with glimepiride. And what it conclusively shows is that the glycemic efficacy of adding sitagliptin to metformin was almost equal to adding glipizide to metformin or glimepiride to metformin. So in terms of glycemic efficacy, they were the same. The durability of sitagliptin metformin was much better. The beta cell dysfunction deteriorated much lesser with sitagliptin. The hypoglycemia was much lesser with sitagliptin metformin. And also the weight loss was much better with sitagliptin metformin, and on the contrary, you had weight gain with an SU plus metformin. Another question in physician's mind is always, are the DPP-4 working as quick as SUs? Because when patient comes to a doctor, the patient would do the blood sugar the next week and report that my sugars are still high. So this is always a query, that whether the DPP-4 inhibitors work as fast as an SU would work. And this specific study was done in an elderly group, which is an area where not many studies are done. So this is a study done in patients more than 65 years of age. The mean age of patients was almost 72. The mean HbA1c was almost 7.8. So randomized, double-blind, placebo-controlled parallel group studies conducted in almost 52 sites. And it shows that right from the third day onwards, you have a decent drop of fasting plasma glucose and average blood glucose when patients are added to an SU. This is a monotherapy of sitagliptin, and it conclusively shows that it is quick and efficacious, and fairly efficacious in patients above 65 years of age. So in terms of efficacy, when you have to choose between an SU and a DPP-4, especially sitagliptin, is almost the same. So that query or cobweb in our mind is cleared. The next comes hypoglycemia. We don't want patients to call up the next day morning saying that I'm in hypoglycemia. And again, the same study between the 2-year study comparing a combination of sitagliptin plus metformin versus glipizide plus metformin, and sitagliptin plus metformin versus glimepiride plus metformin. You can see there's a large difference in hypoglycemic rate between the SU-MET combination and the DPP-4-MET combination. Obviously, patients who are on DPP-4-MET combination are on much lesser risk of hypoglycemia as compared to SU plus MET combination. This is a kind of sub-analysis of the same study, and what it shows is that patients who are on glipizide plus metformin combination have a much higher risk, almost 448 events as compared to probably just 31 events with sitagliptin plus metformin. What is most striking is that patients above the age of 65 who are using glipizide plus metformin have a higher incidence of hypoglycemia as compared to patients who are using glipizide plus metformin below the age of 65. And if we compare sitagliptin metformin in the age groups below 65 or above 65, the incidence rate remains the same. So probably SUs give much higher chances of hypoglycemia in elderly age groups. We don't know the mechanism, probably hypo-unawareness, probably beta cell fatigue, probably social considerations. We really don't know, but SUs above the age of 65 is giving a much higher incidence of hypoglycemia as compared to SU plus MET below the age of 65. So especially in our age groups above 65, as we saw in the previous study also, it's efficacious, it's quick, lesser hypoglycemia, and obviously lesser weight gain. This was a study by Dr. Arvind, which was published around 2 years back. And this was done during this time, that's Ramzan season. And it was just switching patients who are on SU combinations to a DPP-4 combination, especially sitagliptin. And what it showed is that there was a 50% reduction in hypoglycemia. This was a study done in Southeast Asia. And it told us that especially during the Ramzan months, if you just switch over from a SU to DPP-4 MET, the chances of getting hypoglycemia is reduced by almost 50%. And this holds true in real life scenario also. The DIREGIS study was a registry from Germany in primary care setting, and it also told us the same thing, that sitagliptin plus SU in a real world, they almost had 3,810 patients, and the reduction in plasma glucose was much better than a DPP with a DPP-4 metformin, and much lesser incidence of hypoglycemia. Weight is a very important factor because we are treating diabetes, which also involves a lot of quality of life issues. And if you compare the weight difference using sitagliptin metformin versus glipizide metformin, or sitagliptin metformin versus glimepiride metformin, the weight difference is as high as 2.3 to 2 kilograms. The study on the left is a 2-year study, the study on the right is a 30-week study. So you have a difference of almost 2.5 kilograms. So that's something which we need to keep in mind when we are actually choosing a molecule after metformin. CV safety. CV safety has always been on our forefront and in our minds, because majority of our diabetics are going to die of heart disease. There was a myth around 15 years back that some of the newer SUs have lesser cardiac side effects. The UGDP controversy almost 40 years back has still not died down, and a lot of authors still think that probably SUs have some cardiovascular effect, and we need to be careful while prescribing SUs. Meta-analysis using SU versus gliptin on CV outcome conclusively shows that the CV outcomes using a DPP-4 combination is much, much, much better. The cardiovascular safety of sulfonylureas have always been a question mark, and a meta-analysis was done including all trials with a duration of more than six months. There are almost more than 100 trials in this, and it showed conclusively that the use of SU is associated with increased mortality and a higher risk of stroke, whereas the overall incidence of major adverse cardiovascular events appears to be unaffected. It again told us that probably we need to use medications which have glucose-lowering agents, which have glucose-lowering effects and not much of cardiovascular problems such as the DPP-4 inhibitors. This was a poster which was, I think, came in last year's ADA, and the aim of this study was to evaluate the risk of all-cause mortality. We are not looking at cardiovascular disease and all-cause mortality, and patients who were on SU combinations were compared to DPP-4 combination, and the conclusion was there was a consistent reduction in mortality for patients prescribing metformin in combination with DPP-4 versus metformin in combination with SU. These data should be considered because apart from cardiovascular disease, the all-cause mortality in our diabetic population is very, very high. By the end of the year, we would have TECOS which comes in, and probably we would have much more analysis of it, and we'll have a prospective study which tells us the cardiovascular safety of sitagliptin. We need to understand that whenever we prescribe a molecule, we need to take into consideration a lot of comorbidities, whether it's coronary artery disease, heart failure, CKD status, liver status, NAFLDs, hypoglycemic risk, social status of the patient, what is his immediate help. All these things need to take into consideration. And then we have all the other OADs on the right, which are metformin, SUs, TZDs, and also the effect of incretin-based therapies. Durability is something which we need to really look at. We've always seen or heard studies which tell us that probably there is beta cell dysfunction which occurs in type 2 diabetes, and this is a progressive disorder. But we've never had actual data showing that, and this is the data which is obtained from pancreatic islets, which are isolated from 6 type 2 diabetes organ donors and 10 non-diabetic cadaveric organ donors, which tell us that there's increased beta cell apoptosis which occurs in type 2 diabetes. There's decreased insulin content in these islets in type 2 diabetes, and the insulin secretory granules are also much lesser in these patients. And we need to understand that we have a patient who has almost beta cell dysfunction of 50 to 70%, and it is progressing with time. There's a clinical entity called secondary sulfonylurea failure, that once we use a 1 milligram dose of a drug, 6 months later you're going up to 2, a year later you're going up to 4, and finally the patient is on insulin. We sometimes say that it's because of the progressive nature of type 2 diabetes, but we never wonder that probably it's also the drug which is causing it. And that there is some evidence to that, because the SUs keep on stimulating the pancreas even in the absence of glucose. The sustained influx of calcium which occurs is known to cause apoptosis in beta cells. And the conclusion of this study was that SU should be delayed as long as possible because there is increased apoptosis with SU use. We've also not understood that why do we have apoptosis. This was another study where they examined the effects of various sulfonylureas and a short-acting natiglinide on oxidative stress and apoptosis using a beta cell line MIN6. And what it shows is that there is oxidative stress which occurs when we use sulfonylurea therapy, and probably that is the hypothesis which may be contributing to sulfonylurea failure very early in type 2 diabetes. So sulfonylurea beta cell apoptosis does occur in vitro, and we need to find that out. And that's probably one of the reasons that we all know that the sulfonylureas do not have durability. And the whole idea of treating to fail approach doesn't hold true. We need to be much more proactive and probably attack much earlier. So we know that the sulfonylureas lack glycemic durability, and they fail to prevent the progressive decline of beta cell over a period of time. ADOPT study, the larger monotherapy failure with glibenclamide was seen. It showed that the TZDs had a durability effect. Unfortunately, now the TZDs have gone out of repute. But as such, the annual rate of decline in HOMA beta was highest with sulfonylurea versus metformin and then TZD, ultimately mirroring a lack of beta cell survival. In terms of durability, sitagliptin is fairly durable as monotherapy or add-on therapy, as you can see over a period of 2 years. That's what we want, one single dose, no complex situations, durability, patient has good HbA1c for a prolonged period of time. And sitagliptin improves certain markers of beta cell function, whether it's pro-insulin, insulin ratio, or reduces the insulin resistance as measured by the HOMA-B. This is a study which was done to assess the efficacy of an add-on as a third drug of sitagliptin versus glibenclamide on patients who are already on pioglitazone metformin, was published around last year, and it told us all the factors which are in favor of beta cell dysfunction are increased with therapy with an SU, whether it's the pro-insulin insulin ratio or it's the increase in HOMA resistance. So sitagliptin and beta cell markers, one can say that sitagliptin improves the insulin secretory capacity, reduces insulin resistance, and it reduces the beta cell stress and the immature insulin. So in terms of choosing which drug to choose, we have had a lot of reasons that why we should be choosing sitagliptin. Cost, I think cost is in terms of a scientific conversation, of a scientific dialogue or a debate, I don't think cost should be a factor at all. And 1,000 rupees per month is not a factor if you have to prevent large-scale diabetes complications, which may go up to lakhs of rupees per month. So in terms of cost, I don't think cost is a major factor. But what does the algorithm of ACE say? That therapies with complementary mechanism of action must typically be used in combination for optimal glycemic control. Safety and efficacy should be given higher priorities. One hypoglycemic episode in the city of Mumbai would cost around 20,000 rupees a day. So 1,000 rupees a month is not much. So in terms of cost, I don't think there should be a scientific discussion. In terms of mechanism of action, I'm told Dr. Avdesh Kumar is going to tell us more about how DPP-4 acts, not via the GLP-1 action. But one needs to understand that most of these DPP-4 inhibitors are acting only when the glucose is high. Glucose is the best stimulator of insulin secretion. What it does, it increases the ATP-ADP ratio, potassium channel closes, the calcium channels open up, calcium influx, and you have exocytosis of insulin. Now, in the absence of glucose, these DPP-4 inhibitors do not work. They need the presence of glucose, then only they work, which makes DPP-4 inhibitors actually insulinotropic. So they are like a smart drug which work when the sugars are high and do not work when the sugars are low, making our quality of life and the patient's quality of life much better. I think I've given enough reasons for using sitagliptin as a first choice following metformin failure. And also one needs to understand that paradoxical hyperglucagonemia is a pathophysiological defect in patients with type 2 diabetes. I can see Shashank smiling there. Paradoxical hyperglucagonemia is a defect which we have known, and probably we need drugs to kind of reduce on that kind of defect. And we have a drug which has a desirable mechanism of action, has good efficacy. Cost is around 1,000 rupees a month. In terms of some cases of pancreatitis, this is by Dr. Garg, which was presented almost 4 years back. Retrospective data told us that the incidence of pancreatitis is high in patients with type 2 diabetes, but there was no association which was found between the usage of a GLP-1 or a DPP-4 and pancreatitis. So that clears our doubt. The FDA sides with the EMA on the usage of this drug. And in terms of all possible benefits, if you can compare the two, if 1,000 rupees a day to prevent a a 5 lakh rupee deficit is not much. We should all be using DPP-4 inhibitors as the first choice after metformin. So when we have options, what do we have to do? If we have to avoid hypoglycemia, we have to use metformin, DPP-4, TZDs, all a GLP-1 receptor analog. If you have to avoid weight gain, metformin, DPP-4 or GLP-1 receptor analog. Minimize the cost, you have to add metformin, SU and insulin. No longer insulins are cheaper. So choosing a right partner for metformin, I don't think there is a dilemma. We have to choose the right drug, and that seems to be a DPP-4 inhibitor. Metformin is the initial preferred agent in diabetes after diet and exercise. There's a myth that SU has a stronger anti-diabetic action, but with a much higher risk of weight gain and hypoglycemia. SU has a long track record. Gliptins are new, available evidence showing good side effect profile. Possible beta cell preservation and CV benefits are major positives of gliptins versus SU. Gliptins probably may be costlier than SU, but we need to make a cost-benefit ratio there. And I hope, I hope I have helped you all in devising a strategy. This is the team which helps me in my clinic. Thank you so much.
Thank you, Dr. Rajiv. It was a very, very lucid presentation, and you have put your thoughts very, very nicely and very clearly. The question and answer session will be at the end of the 3 talks, after all the 3 speakers finish their time. And then it is also decided to write down the questions on a paper and send it through the volunteers of the symposium. Now, I hand it over to Dr. Padmanabhan.
Thanks, Dr. Vijay Kumar, for moderating and summarizing interesting points on the same. Thanks, Dr. Rajiv Koil, to clear the dilemma and choose what is required after metformin. Now we will move on to the second session. To chair the second topic, I am pleased to welcome Dr. Venkatraman. Dr. Venkatraman, consultant diabetologist from Apollo Hospitals and Surya Hospitals, Chennai. Dr. Venkatraman is an active speaker and chairperson in many national forums. I welcome Dr. Venkatraman to the dais to do the proceedings.
So good evening, everybody. At the outset, I think I would like to profoundly thank MSD for this opportunity to be in the midst of my friends and galaxy of speakers for this excellent symposium. I think as a brief introduction, it will be pertinent to point out that till the early part of this century, when we as clinicians realized that good glycemic control in the early part of the disease is of paramount importance in preventing the vascular complications, we always used to tell ourselves and also remind our junior colleagues that an ideal oral anti-diabetic drug should be. I mean, at that point of time, only the sulfonylureas were the major players from the secretagogue correction point of view. So an ideal oral anti-diabetic drug should be capable of facilitating insulin secretion when there is hyperglycemia, switch off the insulin production when the sugar more or less reaches the euglycemic level, try to address the issue of weight gain, and possibly target the hyperglycogonemia. This was a wishful expectation of the clinicians across the world when we realized that good glycemic control is of paramount importance, and to be handy to us for use in this scenario to fulfill these aspirations, we had the first DPP-4 inhibitor, that's the sitagliptin, and subsequently many DPP-4 inhibitors have been introduced. So the last almost a decade of their usage has thrown a lot of light not only about their mechanism of action, in what clinical scenario you're able to use these molecules, and also the extra glycemic benefits that these molecules offer to the clinicians. I think to elaborate more on this interesting subject, we have Dr. Avdesh Kumar Singh from Guwahati. He is a chief consultant endocrinologist and diabetologist from Sun Valley Diabetes Research Center and Hospital, Guwahati. and he has immensely contributed to various journals, peer-reviewed journals, and also in textbooks of diabetes. He has got about 25 publications, and an eloquent speaker, most sought after in most of the national meetings. Dr. A.K. Singh.
Thank you, Mr. Chairman, sir. Thank you, Dr. Krishna, organizers, for inviting me to such a grand place. My topic is a little bit different in the sense it fits into the actual science of trendo, emerging trends in endocrinology and diabetes. So in this 20 minutes, what I am going to talk today is to tell you a fascinating emerging aspect of DPP-4 inhibitor and their mechanism of actions. Now you'll wonder, what is big deal about that? We all know how DPP-4 acts. And I will give you a little bit of, skewing in the things. What we were knowing may not be exactly correct, and there are so many things to know what is there in DPP-4 inhibitor and why it is acting in a different way. So let's take you some basic idea. We all know that the pharmacological actions of GLP-1 agonists like liraglutide, exenatide, and so many GLP-1 agonists are largely predictable. You inject it, the GLP-1 level goes up, it goes to the pharmacological range, almost 10-fold rise of GLP-1. You don't need endogenous GLP-1. Whether patient secretes endogenous GLP-1 doesn't matter to them if you inject GLP-1 agonist. And they are not susceptible to DPP-4 inactivations. So that is a very clear-cut aspect of how GLP-1 agonist acts. We also know that if you increase this GLP-1 level to the pharmacological range by injecting a GLP-1 agonist, it directly acts on GLP-1 receptor on beta cell and produce the therapeutic effect by insulin release. However, the mechanism of DPP-4 inhibitor is relatively less clear. Why it is less clear? I will tell you. So if you see what happens to the GLP-1 when it is secreted from L cells in the ileum, immediately it is broken down. So you could see 75% of GLP-1 which is secreted from L cells in ileum is immediately broken down into an inactive peptide. The rest 25% actually reaches to the liver. Out of this 25%, again 50% is metabolized in the liver, and only 10 to 15% are left behind to do something in terms of reducing blood glucose. Is it enough? Whether 10% of GLP-1 which is coming out if you give a DPP-4 inhibitor is fine enough to produce their metabolic actions, this is what I am going to talk today. So why it is less clear with the DPP-4 inhibitor? We all know how the DPP-4 inhibitor acts. They act on endogenous GLP-1. So my L cell has to secrete some endogenous GLP-1, then only DPP-4 inhibitor will act. If my L cell doesn't secrete GLP-1, DPP-4 inhibitor classically should not have any actions. But what is interesting is, if you give a DPP-4 inhibitor, the GLP-1 rise are very trivial. If you see the literature, they suggest 1.5 to 3-fold, but this is questioned nowadays. But the rise of GLP-1 will dependent upon the endogenous GLP-1 secretion. So if you differentiate from a GLP-1 agonist, you don't need endogenous GLP-1. For a DPP-4 inhibitor, there has to be endogenous GLP-1 to act, to have a, actions with the DPP-4 inhibitor. But what is interesting is if you use a DPP-4 inhibitor, whatever gliptins you have, sitagliptin, vildagliptin, linagliptin, sexagliptin, they almost achieve 85 to 97% of DPP-4 inhibition. But what happens to that? The half-life of GLP-1 hardly increases from the 1 minute to 5 minutes. And also if you see their residence time in the circulation, that also remains pretty short. That asks the questions whether this trivial rise of GLP-1 with DPP-4 inhibitor are good enough to engage GLP-1 receptor in beta cell, and this is what I am going to talk today. So this is the background idea, what I am going to tell you, how DPP-4 inhibitor is acting other than GLP-1. So then scientists would like to know whether DPP-4 inhibitor is acting through the GLP-1 receptor. So what they did is, in a mouse model, they knocked out the GLP-1 receptor. They have given DPP-4 inhibitor to the mouse model, and they could see that blood sugar is going down. In spite of having no GLP-1 receptor, if you give a DPP-4 inhibitor, it is still working. That leads a question whether DPP-4 inhibitor is acting through a GLP-1 receptor. So they thought that the DPP-4 inhibitor might be working through GIP receptor. So when you block the GLP-1 receptor, it would be a GIP receptor which would be probably super active with a DPP-4 inhibitor. So what they did is they knocked out even the GIP receptor. So this is a double incretin receptor knockout mouse, Derco mouse, when they knocked out both GLP-1 and GIP-1 receptor, and they give the DPP-4 inhibitor, then they find there is no substantial reduction in blood glucose. So they concluded that for the DPP-4 inhibitor, you do need GLP-1 receptor for the mechanism of action. Michael Nock and group, and they challenged this concept. So this was the paper published in Diabetologia by Michael Nock group, and they immediately challenged whether DPP-4 inhibitions and their mechanism of glucose lowering is mediated through GLP-1. And you could see these were the four conclusions, that it is unlikely that the trivial rise of GLP-1 by DPP-4 inhibitor is accounting for the desirable glycemic effect with DPP-4 inhibitor. Now, another aspect too, very interesting, this is, my paper is under publications, and I tried to collaborate the head-to-head study of a DPP-4 inhibitor versus a GLP-1 agonist. So you could see there are 10 trials here. This is a head-to-head trial of a DPP-4 inhibitor versus a GLP-1 agonist. If you see the lower 4 study in the lower panel, this is the longer-acting GLP-1 agonist. Longer means once weekly GLP-1 agonist. And you could easily find out that they have clearly beaten DPP-4 inhibitor in all parameters, whether it's a fasting, it's a prandial, HbA1c, or patients achieving target of less than 7%. So the longer acting once weekly GLP-1 agonists were clearly superior to a DPP-4 inhibitor. But if you look into the upper 4 study, head-to-head study of GLP-1 agonist versus DPP-4, the data is very interesting. See, now our original thought that GLP-1 agonist is much more robust in increasing GLP-1 to pharmacological rise to tenfold, but when you have a head-to-head study of DPP-4 with a shorter acting GLP-1 agonist like exenatide twice daily or with a lixisenatide head-to-head, you can't find any gross superiority of short-acting GLP-1. And in middle column, you could see 2 head-to-head study with liraglutide. In one study head-to-head with lira, they showed superiority of lira over sitagliptin, but in another study, they could not achieve the superiority head-to-head with DPP-4 inhibitor. This study, and then thereafter meta-analysis done, you could see the Caroline did the meta-analysis, and they could clearly make out that shorter acting GLP-1 agonist was not found to be clearly superior to DPP-4 inhibitor, except the longer acting GLP-1 agonist. This meta-analysis and head-to-head study represents a conundrum that the clinical benefits as measured by HbA1c does not dramatically differ between a DPP-4 inhibitor and GLP-1 agonist. And these are the reasons why we are looking for a newer episodes of mechanism with DPP-4 inhibitor. So what could have possibly happened with this head-to-head study? There could be 2 possibilities. Number 1, whether subcutaneous GLP-1 agonists are less than expected response. Is there any reasons for less than expected response with GLP-1 agonist? This could be one possibility. The another possibility would be whether there is a little more response with DPP-4 inhibitor than what we are expecting. So let's take one by one. What could be the reasons with less than expected response with GLP-1 agonist? So let's see. If you compare with a subcutaneous GLP-1 agonist versus a native GLP-1, if you give a IV GLP-1, it immediately makes you normoglycemic. But if you give a subcutaneous GLP-1 agonist, blood sugar comes down, but not to the normoglycemia. And you have got a unknown, untoward GI side effect. So there is a difference between intravenous and subcutaneous GLP-1 formulations. Even if you give a subcutaneous GLP-1 infusion, you will not get the desirable effect as the IV GLP-1. So what could be the possible reason? These are the possible reasons. If you give through the subcutaneous GLP-1 agonist, like let's say injection liraglutide, Victoza, we only found out a peak GLP-1 which is lasting for 1 to 1.5 hours. If you give a subcutaneous GLP-1, their bioavailability are much lower. You could see the 20% lower bioavailability if you give a subcutaneous injection of liraglutide or exenatide. And interestingly, you cannot use the largest dose of GLP-1 because it produces, the side effect of nausea and vomiting before they could achieve glucose lowering effect. So what could be the possibility that if you give a subcutaneous GLP-1 injection, there could be some modifications in the adipose tissue which probably fastly metabolize GLP-1 agonist which you are injecting. Or there could be a possible interactions between the adipose tissue with the GLP-1 agonist. So these are the proposed theory with less than expected response with subcutaneous GLP-1. And that's maybe the reason why GLP-1 agonists are not looking far, far superior over DPP-4. Whereas, if you look into the DPP-4 inhibitor, they may have some another mechanism of glucose lowering. What are those? So let's go back into a little bit of DPP-4 physiology. There are some DPP-4 substrate which are glucose lowering in nature, of which 3 DPP-4 substrate like pituitary adenyl cyclase peptidase 38, gastrin-releasing peptide, and recently oxyntomedylate. These are 3 DPP-4 substrate which have a glucose lowering property. So if you give a DPP-4 inhibitor, you could possibly increase these substrate which have a glucose lowering property, and these are very recently published data. Now it is also thought that if you give a DPP-4 inhibitor, there is an alpha cell mediated insulinotropic effect, because alpha cell also expresses and secretes GLP-1 and GIP which exert direct action on the beta cell. So it's a very close effect from alpha cell to beta cell. These are the proposed mechanism for DPP-4 inhibitor induced glucose lowering. The another possibility would be to look into the DPP-4 enzyme activity. So if you see the literature here, and in a type 2 diabetic patients, those who are uncontrolled, they have got a very enhanced DPP-4 activity. So if the endogenous GLP-1's half-life is becoming even shorter. So if you give a DPP-4 inhibitor, you could prolong the GLP-1 by inhibiting the DPP-4. So there was a meta-analysis which suggested that there are 33% increased DPP-4 activity in type 2 diabetes. So if you give a DPP-4 inhibitor, this will abolish the 33% increase in DPP-4 activity and could reduce the blood glucose. And this was the study and the meta-analysis published. So 33% increase. Then nowadays we have got some emerging concept in experimental model that DPP-4 inhibitor might be acting through something completely different pathway. How this mechanism occurred, that moment you take a DPP-4 inhibitor and it has not yet reached into the ileum to the L cell to secrete GLP-1, you are getting the response. So it was thought that something earlier is happening before DPP-4 inhibitors are reaching into the ileums to secrete GLP-1. So there are several theories proposed, although these are experimental and need to be proved in clinical scenario, but these are the proposed mechanism. So you could probably are inhibiting intestinal DPP-4 proximal to the site of GLP-1 secretion, and moment that there is a GLP-1 level locally rising in the upper GI tract, even before it is reaching into the ileum, there is a direct gut to brain to cell axis by which DPP-4 inhibitor might be working. There is another possibility because portal vein and the L cell has got a same innervation, and portal vein has got a highest GLP-1 concentration. So if you give a DPP-4 inhibitor, it is reaching into the portal vein and it is directly producing gut to cell axis effect, which is called portal neural sensing theory. Then it's like a analogy to exogenous versus endogenous insulin. If you give a DPP-4 inhibitor, there is the portal rise of GLP-1. But if you give an injectable GLP-1 agonist, there is a systemic rise of GLP-1. So this portal is to systemic GLP-1 gradient might be doing trick for DPP-4 inhibitor compared to GLP-1 agonist. And this was one of the first study to prove that GIP might be working to reduce blood glucose with DPP-4 inhibitor. Because if you give a DPP-4 inhibitor, there is a rise in the GIP, which is directly stimulating the somatostatin, which has got a reduction of intestinal motility, and this is called paracrine theory. Nowadays, very much focus are put on this concept, which is called dipeptide theory, because I will give you a schematic presentations of this dipeptide theory, and there is now a study to suggest that DPP-4 inhibitor may have a direct GLP-1 secretagogue property. So if you give the data is currently with the sitagliptin, if you give a DPP-4 inhibitor, there could be a direct GLP-1 stimulator from the L cell. So coming back to the dipeptide theory, if you look into the GLP-1, this is the active GLP-1, which is 7 to 36 amide. And with DPP-4 enzyme, it is broken down into inactive 9 to 36 amide and a dipeptide, which is called his-ELA, histidine and alanine amino acid. Same happens with the GIP, and there it is called TYR-ELA, tyrosine and alanine. This dipeptide has got a gluconeogenic property. So if you give a DPP-4 inhibitor, you are abolishing the effect of this dipeptide, and probably this would be one reason, exciting reason how DPP-4 inhibitor might be acting to reduce blood glucose. And just to simplify what I have said into this experimental animal, this is the classical concept of a GLP-1 induced blood glucose lowering. But if you take into account moment the food in the upper GIT, it doesn't need to go into the ileum to secrete GLP-1 from L cell. They directly activate the central nervous system to have a direct effect on beta cell. So this is gut to brain to cell axis theory. Another was, I was telling that food in the upper GI tract, the portal GLP-1 is higher, directly stimulating the beta cell, bypassing all this classical GLP-1 related mechanism. These are emerging experimental evidence with DPP-4 inhibitor. So to summarize what I have said, the action of DPP-4 inhibitor appears only partially dependent upon overall GLP-1. It is required, but there are several factors like, as I said, directly alpha cell mediated response, oxyntomedulin, pituitary adenyl cyclase, portal GLP-1 gradient, GIP as I suggested, and this dipeptide theory, and possible some other, maybe next year when I come back here, I would talk about something new about that, many unidentified substrate which probably also would be responsible to mediating this glucose lowering effect. Thank you very much for your patience hearing.
I think I'm sure all of you will agree that some of the very, very subtle aspects of incretin-based therapy has been put very succinctly by Singh. The question that he raised and then tried to answer was the dichotomy of response between subcutaneous versus intravenous GLP-1 infusion, which all of us are aware of, number one. Number two, the quantum of GLP-1 enhancement that one does achieve with the DPP-4 inhibition may not be adequate enough for the metabolic effects. And he has run through a lot of studies involving animal models and then incorporated the relevant theory to say that the DPP-4 inhibitors, beyond probably prolonging the survival of GLP-1, they act on other complementary mechanisms resulting in the good metabolic as well as the extraglycemic effects which we have seen. As has been explained earlier, I think we'll wait for the third speaker to finish, and now I hand over to Paddu for the next session.
Thanks, Dr. Venkatraman, for moderating and summarizing interesting points on the same. Thanks, Dr. Avdesh Kumar Singh, for really updating us on the advances in the understanding of DPP-4 inhibition and action. To chair the third topic, I am pleased to welcome Dr. Paneerselvam. Dr. Paneerselvam, consultant diabetologist from Aruna Diabetes Center, Chennai. Dr. Paneerselvam has actively participated in various national forums. He has got to his credit some few publications. I welcome Dr. Panneerselvam to the dais to do the proceedings.
Good evening to all of you. After listening to the two topics, the mechanism of action of gliptin and where we have to position the gliptin after metformin, now we are entering into the third topic, the treatment of type 2 diabetes from an endocrinologist, cardiologist and nephrologist point of view, a special approach. Of course, as we all know, all diabetics at one particular point of time they develop some complications, or we deal the case with some comorbidities. The common complication, as we all know, nephrological aspect, diabetic nephropathy and our diabetic cardiomyopathy also. After entering into the complications, how we are going to handle the patients, the various molecules. To talk on the subject, as we all know, he is our national speaker, internationally known, Dr. Shan Joshi. Last week also he was here in Chennai. He acquired MD General Medicine, DM, FACP USA, FAC USA, FRCP Glasgow. Dr. Joshi has been awarded the Best Clinician of the Year 2012 by the American Association of Clinical Endocrinology. He recently honored with Padma Shri, renowned speaker and moderator. He visited Chennai many times. All of us are very friendly to him, and he is a well-known speaker of India. So I welcome to the podium, sir.
Thank you, Dr. Panneerselvam, for your kind words of introduction. This year, having the mantle of API, I have a simple theme of listening, and I'm sure you have listened to very elegant talks from Rajiv and Avdesh. Then you need to learn something from that, but what will you adapt? And as Osler said, medicine is an ever-changing science with a lot of uncertainty, with art of probability. What I have to do in the next maybe 20-25 minutes is tell you the treatment of type 2 diabetes from different specialist views, how an endocrinologist will look at treating type 2 diabetes. And you will see a lot of overlap between my slides as well as Rajiv's slides in that. Lot of hot topics have been debated in cardiology today. Concerns as well as good things about DPP-4 inhibitors and treatment of type 2 diabetes and the CV outcomes. And we've seen stories of rosiglitazone, etc. through the CV route. Then of course the kidney. So when we look at a specialist approach, let us look at how an endocrinologist looks at diabetes. As endocrinologists, we want to look at pathophysiology. And my good friend Krishna always likes to talk a lot on pathophysiology. We need to look at drugs which not only achieve a treatment target, but with no hypoglycemia, weight neutrality or weight loss. They have a very good safety valve. That means they have no or manageable risk profile. They should be easy to combine with other drugs. It should be easy to comply for patients. They must have beneficial effects not only just on beta cells, but also on the liver. Because we are recognizing that in insulin resistance, fatty liver and NASH and non-alcoholic fatty liver disease is coming up as a very big thing. We also are looking at it as an adjunct in other forms of diabetes, like LADA, type 1 diabetes, MODI, and maybe even other endocrine disorders. So we have moved a lot from simple dual defect of beta cell dysfunction and insulin resistance to a glucose output from the liver, which was a triumvirate as DiFranco described it, to an octet and maybe even to a dirty dozen or dirty 13. We definitely still have unmet needs. We need good drugs which have consistent long-term efficacy. We need drugs which are less likely to induce hypoglycemia. We need drugs which have a lot of weight loss efficacy. We need drugs which will reduce risk of CV events. And we also need better methods to assess drugs' disease modification potential. Can they modify the disease process? Can they alter the natural history of the disease? And we also need drugs which can actually have an impact on complications. So obviously, we need to have that unmet need so that we can actually change natural history of diabetes so that the disease does not progress and we can manage cardiovascular and other complications. The ADASD statement of 2012 Rajiv very nicely told us and has multiple pathways, and we have to look at one goal to avoid hypoglycemia. And after metformin, we have three options: glitazones, DPP-4 inhibitors, and GLP-1 agents. Glitazones have their own safety valves and challenges, and the GLP-1 agents have their own safety valves and injections. So gliptins are right there in the center. When we look at goal of weight gain and avoidance of weight gain, obviously the glitazones go out and the gliptins as well as the GLP-1 agents stay there. And when we look at other considerations, and we are in east of the world, someone says that we are in diabetes east, we have more beta cell dysfunction. So we need drugs which can address that also. Rajiv also alluded to the ACE algorithm of 2013. The current trend is healthy patients without concurrent illness, low hypoglycemia risk, hit hard, hit early. Try to keep your A1C below 6.5%. And if you have concurrent illnesses, lot of hypoglycemia risk, you individualize the goal of the patient from 6.5 to 7, 7.5 also. So if you look at the ACE algorithm, at entry, apart from lifestyle modification and medically assisted weight loss, you can use metformin, GLP-1, a gliptin, and a glucosidase inhibitor. Of course, you can also use an SGLT2, which will be soon launched in another couple of months in India, a glitazone, or a secretagogue. And if the A1C does not come down below 6.5 in 3 months, you can go to dual therapy. If the entry level is more than 7.5% but less than 9%, you can go to dual or triple therapy. And if it is more than 9 and you are symptomatic, you need to treat glucotoxicity and give insulin. However, if it is asymptomatic, you can still do dual or triple therapy and or add insulin. This graph also was shown by Rajiv very nicely, that each agents have their pros and cons, whether it is hypoglycemia, weight, renal, genitourinary side effects, GI side effects, cardiac failure, CV risks, and bone. So let's look at metformin. It's neutral for hypoglycemia. It may promote weight loss, but it doesn't meet the US FDA criteria for 5% for weight loss. It has challenges with renal and genitourinary and has GI side effects. With ADOPT data, you could say that it's CHF neutral or maybe a little adverse. It has CV benefits, probably, with 30 years of UK PDS data, and it's neutral for the bone. Gliptins are clearly neutral all throughout, except that in renal diseases, except LINA, you might need a little renal dose adjustment. GLP-1 agents, attractive because they have weight loss, but they have some contraindications, they have some challenges, and they have some GI side effects. Glitazones, great drugs, but their rate limiting step is weight gain, fluid retention, heart failure, macular edema, unusual bone loss and fractures, CHF, and CV benefits unknown. Proactive did show some beneficial data and some questionable concern on bladder cancer in a cumulative dose. Glucosidase inhibitors, very much there apart from GI side effects, but not as strong. I will not talk about Covalcilam because it's not available. Quick release bromocriptine is available in India, but it's really not been extremely popular. Of course, it had GI side effects. It is probably the only agent which got approval by the US FDA after the rosiglitazone CV story and has CV outcome data to it. Then of course you have secretagogues, very much still there, but they have hypoglycemia, mild, moderate, severe. They have weight gain. They are less durable, as Rajiv said. They have more hypoglycemia risk. The CV safety keeps on getting questioned recurrently, but they are neutral on the bone and heart. Insulin, of course, is very much there, SGLT2 and pramlintide. So obviously when we look at the algorithm, we need individualized targets. Medical therapy is not a failure of lifestyle modification, but an adjunct to lifestyle modification. We need individualized therapy looking at risk of hypo, weight gain, ease of use, cost and safety, which Rajiv was alluding to, and of course an effect on kidney, heart and liver, and have complementary mechanism of actions and safety and efficacy are the highest priorities. So if you look at all anti-diabetic drugs with A1C reduction, weight gain and risk of hypoglycemia, you can see here the A1C reduction may be similar, but when it comes down to weight gain and risk of hypoglycemia, the secretagogues, the glitazones, the AGIs, you can see the relative risk of hypoglycemia is very different. And when you look at weight change, again the glitazones and secretagogues go out there. So obviously, the clinical composite when you are looking at a drug, we want three things: weight neutrality or weight loss, we want definitely no hypoglycemia, and we definitely want a good robust A1C reduction. And probably the gliptins are very much there, and they have clearly been there. You can see a single dose of sitagliptin, and Avdesh very nicely told, has a twofold increase in active GLP-1 and GIP. There's a 22% better output in a glucose-dependent fashion of insulin on the beta cells. There is a alpha switch off of a 12% reduction of glucagon by sitagliptin, and there is a 26% reduction of area under the curve of plasma glucose. That's exactly what a single tablet of sitagliptin will do if we give it in a physiological state. And that is the evidence-based confirmation. So efficacy to efficacy in monotherapy, A1C has a robust drop. After metformin, robust drop. SU plus metformin is a third agent, robust drop. After pioglitazone, robust drop. With insulin, with metformin, again a robust drop. So clear-cut efficacy data. Can it improve markers of beta cell function? Of course. Favorable pro-insulin to insulin ratio, better HOMA beta models. Rajiv showed us this slide, better insulin secretory capacity, decrease insulin resistance, decrease ER stress of the beta cell and immature insulin. Let me move to the next point. We are seeing with diabetes a clear twofold risk of chronic non-alcoholic liver disease. And we have seen that very aggressively. You can see here data published from east of India or from west of India. And you can very clearly see that histological nephrology, steatohepatitis and fibrosis with diabetes is as high as 87%, 62% and 37% in the Indian population. This was a study done at KM Hospital. I was one of the authors of that study, and Prashant Mappa did this as a DM thesis, and he presented at the Endocrine Society meeting in Boston a couple of years back. If we look at hepatic insufficiency and common oral anti-diabetic drugs, metformin is a hepatoselective drug, and we do not have pharmacokinetic studies conducted in patients with hepatic insufficiency. So we have a caveat with that. Glimepiride, again we don't have studies performed in hepatic insufficiency, and therefore we need to be very conservative with that drug. Glipizide has data to show that there is prolonged hypoglycemia after hepatic impairment. Gliclazide, again precaution with hepatic impairment, and is contraindicated in severe hepatic impairment. With acarbose or AGIs, we are clearly knowing that the transaminitis occurs, and they have suggested a rate limiting step. With pioglitazone, there is no dose adjustment needed for hepatic impairment, but they said that if there are post-marketing reports of liver failure with pioglitazone, and you need to be careful if the enzymes go 2.5 above. What about the European recommendations for gliptins with hepatic impairment? For SITA, no dose adjustment is required for mild to moderate hepatic impairment, but in severe hepatic impairment, it has not been studied. With LINA, they say there is no dose adjustment requirement, but clinical experience is lacking. Similar data is available with Saxa, and vildagliptin did not get US FDA approval because of the hepatotoxicity which was observed with the 100 milligram dose. So what is the effect of these incretins or gliptins on gastrointestinal and hepatobiliary system? Appetite suppression, delaying gastric emptying causing better prandial satiety, weight reduction as a cumulative effect of central appetite suppression as well as modulation of peripheral taste and gastric slowing, better beta cell health, suppression of glucagon, so better alpha cell dysfunction, and GLP-1 is hepatoprotective for hepatosteatosis. So if you look at anti-diabetic agents and gliptins or GLP-1 for NASH or NAFLD, due to prolonged GLP-1 receptor activation, there is weight reduction, there is improvement of hepatic insulin sensitivity, there is data to show that the hepatic fatty acid oxidation is improved, and there's also data to show that the hepatic fibrosis is inhibited by inhibition of fibroblast growth factor 21. So this is the mechanistic view that the gliptins may have a very attractive role, particularly sitagliptin has data on it, on weight, liver insulin sensitivity, liver fatty acid oxidation, and inhibition of fibroblast growth factor 21, and improvement of NFALD and NASH. So when we look at data with sitagliptin in hepatic impairment, diabetes with NFALD, there is a very nice study, 48 weeks, fasting and A1C improved with sitagliptin, no change in the enzymes. Diabetes complicated by hepatitis C, again data on sitagliptin, no change in the enzymes, and excellent A1C and fasting reduction. Treating diabetes with NFALD, 16-week data showing A1C drop, glucose drop, and gamma GT or ALT AST has been untouched. Looking at effect on insulin resistance and steatosis, there is a case report to show that even on histology, the severity of hepatic steatosis has improved with sitagliptin. And diabetes complicated by NASH, again with liver scores, decrease ballooning and NASH scores, decrease in the steatosis score in a 3-month trial and with sitagliptin. Let's move from liver to other types of diabetes from the endocrine standpoint. You can see a data published in JCNM recently where they use sitagliptin in patients with LADA, type 1.5 diabetes, where they have shown it maintains beta cell dysfunction and it has an impact on recent diabetes. We have data from 2 studies now in type 1 diabetes with sitagliptin. First was the study which came from Satish Garg, and second is the Elias study. Both the studies have shown that in type 1 diabetes, there is a lot of overactivity of the alpha cells. And it is important to control that excess glucagon and improve the brittleness of type 1 diabetes. And there is now data to suggest that it could be an adjuvant in type 1 diabetes. And this you can see here, better glucose control, lower insulin dose in type 1 diabetes. Another second peak of type 2 diabetes which is occurring is adolescent type 2 diabetes. And in adolescent type 2 diabetes, you can see here very, very clearly good data from sitagliptin, where there is data to show that it can be used in this population. And you can see here the ratio of active to total GLP-1 over time is better. There is very good data also on sitagliptin that in postmenopausal diabetic women, it positively regulates the bone metabolism, the osteocalcin, the bone mineral density, the urinary telopeptides are positively impacted. And probably there is a bone protective mechanism with the gliptin. So from the endocrine standpoint, whether it is the liver, whether it is the pancreas, whether it is LADA, whether it is type 1, or whether it is looking at the bones, this were the perspective from an endocrine standpoint. However, the biggest skeptics of anti-diabetic drugs are our cardiology colleagues. They have put, cardiologists have interfered with diabetes to the extent that endocrinologists have de-recognized the term called metabolic syndrome, because they found cardiologists, because of the excessive use of statins in the US and Europe, have started interfering with endocrine and diabetes practice. Cardiologists have always been skeptical of anti-diabetic drugs. It started from the tolbutamide story. Then of course you had the typical 10-year follow-up with intensive glucose in type 2 diabetes with UKPDS. But one thing came out after 30 years of UKPDS. Rory Hulman, who continued the legacy of Bob Turner, clearly showed that hit hard, hit early, because if you hit hard, hit early in the first decade of a diabetic's life, you will generate legacy effect, you will generate metabolic memory, and you will be able to control your patients better. If you look at across board all agencies now, whether it's American Diabetic Association, American Heart Association, American College of Cardiology, they feel A1C less than 7% in newly diagnosed patients is likely to have benefit with long-standing diabetes and CVD. Benefits may not be completely proven. However, very tight control below 7% is best for people with short duration of the disease, long life expectancy, and no cardiovascular disease. That's the caveat. There has been concerns from secretagogues. For example, this was a retrospective cohort. We have challenges with retrospective cohorts where they showed SUs might increase CVD risk and mortality from a UK-based research database of this thing. We all know the CV risk profile which Steve Nissen bought out from the GSK database, and we know that there is a full U-turn now. US FDA has now said that probably rosiglitazone is a CV safe agent. So obviously they did see some signal. The record is full of its own controversies. So obviously the GLP-1 has different targets. They may be neuroprotective. This data, and Dan Drucker this year in the Banting oration showed us data of GLP-2 in neuroprotection even in Alzheimer's disease. We have data on cardioprotection, but it could also be a challenge with heart failure, and let us look at some of that data. We know that GLP-1 receptors are expressed on cardiomyocytes, endocardium, microvascular endothelium, and coronary muscle cells. There is mechanistic data to show that CV risk modulation might be positively impacted, because there is a study going on that the myocardial infarct size may be decreased, endothelial function may be improved, inflammation oxidative stress may be decreased, atherosclerotic plaque volume may be reduced, LVEF may be improved, triglycerides and blood pressure can come down with the gliptin. So obviously why does that occur? Because DPP-4 substrates directly or indirectly regulate cardiovascular functions. What are the DPP-4 substrates? Let us look at 4 of them. BNP, brain natriuretic peptide, substance P, neuropeptide Y, and peptide YY. What is BNP? BNP is secreted by the ventricles in response to excessive stretching of the cardiomyocytes. It leads to decrease in blood volume, thus lowering systemic blood pressure and afterloads, and yields to an increased output of cardiac output. So what happens to BNP? Substance P, it is released from terminals of specific sensory nerves associated with inflammation process and pain, but has a potent vasodilator and a nitric oxide release effect, which is the positive thing. Neuropeptide Y, it's a neurotransmitter of the brain and autonomic nervous system, increases and modulates food intake, energy, fat store, anxiety and stress, pain perception, circadian rhythm, and blood pressure. Peptide YY is often called as the ileal brake because ileum and colon secretes it as a response to feeding. It inhibits gastric motility, increases water electrolyte absorption in the colon, suppresses pancreatic secretion, and most importantly, blunts of appetite. Here is data to show that sitagliptin improves myocardial response to dobutamine stress in patients with documented coronary artery disease. There was a significant increase in ejection fraction, enhanced So I think Avdesh and me are following. I think the computer is tired of us, and improved contractile velocity in ischemic segments. Sitagliptin in a dose-dependent fashion also reduces the carotid intima medial thickness after a balloon injury in animal models. You can see here it has a protective property against restenosis after a carotid injury, and in large vessels it could have a challenge. Post-coronary syndromes in Israel, they analyzed the ACIS 2010 data, and they clearly showed with MACE data that sitagliptin was cardioprotective. Avdesh alluded to this point that the reduced CD26 expression is associated with improved cardiac function after myocardial infarction, and therefore if you, there is a sitagramy trial which is ongoing, that if you treat patients shortly post MI with sitagliptin to inhibit CD26, it will increase the mononuclear cell homing to the infarct area, and which will probably enhance cardiac recovery and repair, and this is published data. If you look at the odds ratio of cardiovascular safety, currently the odds ratio is around, from indirect data, the MACE data, the CITA CV safety data submitted to the FDA is 0.67 and 0.68, which is favorable. Other gliptins also appear to be favorable. There is no CV signal which is observed. However, we have two trials on CV outcomes on gliptins published. The data was reassuring and disappointing both. Saver-Timmy 53, published by Eugene Braunwald and their group from the Mass General Harvard group and Beth Israel group, clearly showed that saxagliptin was CV neutral, but did not meet the primary efficacy objective. However, there was a concern. What was the concern from the Saver-Timmy data? That there was an increase of hospitalizations from heart failure with a hazard ratio of 1.27. The good thing was the pancreatic safety was, there was no increase in incidence of pancreatitis, but the CV hazard ratio was right at 1. The other trial which was there, simultaneously completed in 2013, was the examined trial for allogliptin. Again, the hazard ratio was 0.96. So both show CV neutrality. However, no increase in pancreatitis with examined and allogliptin, but again increased hospitalization of heart failure. The ongoing TCOS trial with sitagliptin will end in December 2014. It has a different cohort of patients completely, much larger size, much larger number of patient years, and we will have to await the results of TCOS to finally have the verdict of this. There is Carolina trial which is also observed, and Vivid trial of vildagliptin is already published. So this was the Saver-Timmy and examined data which showed neutrality, and that is where the cardiac story rests. Let us look at now the nephrologist view. We know CKD and type 2 diabetes go hand in hand. We know there is a lot of end-stage renal disease, and hypoglycemia is huge in CKD because we all know the various mechanisms. And in CKD, the optimum A1C is a challenge. Why with patients with CKD have an increased risk of hypoglycemia? Because we all know that there is decreased renal glucose production. We also know that in CKD there is reduced gluconeogenesis in the liver with decreased mitochondrial ATP to ADP ratio. We also know in CKD the glycogen reserve of the body is depleted. We also know that in CKD there is a reduced or a blunted systemic response to adrenaline and glucagon. But the major factor which causes hypoglycemia is the insulin clearance of various hypoglycemic agents, oral or injectable, and their metabolites is reduced, and there is a decreased insulin degradation. So due to all these factors, hypoglycemia is a big challenge in CKD patients. There is another fallacy which we must observe with CKD patients as clinicians, the fallacy in A1C. In CKD, A1C is highly unreliable. Why? Because you could get a falsely elevated A1C, because we all know that with CKD there is carbamylation of erythrocytes. So you could get a very high A1C. You could also, on the opposite side, get a falsely decreased A1C, because we know if somebody is taking iron or using erythropoietin with CKD, the A1C is likely to be falsely depleted or low. Also due to increased erythrocyte turnover in CKD, because in CKD body is trying to have better erythrocyte turnover, you will get falsely decreased A1C. So remember, A1C is very unreliable in CKD patients, and therefore you need not rely on them. What about metformin in CKD? Traditionally, metformin was always contraindicated in CKD, but there has been a little change. We need to look at CKD and look at EGFR. When we look at EGFR more than 60, no renal contraindication for metformin, monitor renal function annually except age 80 and above. Above 80 years of age, you have a clear relative contraindication for metformin. Between 60 and 45, you can use metformin, and there is a change there, and probably you need better renal function monitoring. Between 45 and 30, you need to use metformin with caution, use it with half maximal dose, more closer monitoring of renal function, and do not start new patients on metformin, and below 30, don't use it. However, there is an additional caution. If there is acute kidney injury or a huge fluctuation in renal status or electrolyte disturbances, avoid metformin completely. What about sulfonylureas in CKD? We need to know clinically relevant pharmacokinetics of glipizide, gliclazide, glimepiride. Their half-lives, their active metabolites, their bioavailability, their molecular weights, and their excretion potentials. If you look at all the three agents very actively, we need to be very careful in using secretagogues or glynides. Among all of them, we know that the active metabolite of glimepiride is probably going to stay longer with renal disease. Gliclazide also has a more propensity for hypoglycemia. Glipizide and ripaglinide might be the preferred agents in this class if one has to use them in CKD. What about glitazones? No dose adjustment has been required. There is no hypoglycemia. However, the chances with sodium and water retention and heart failure are higher if there is glitazones with CKD, and dialysis data is not there with glitazones. Therefore, there is a caution recommended that if you want to use pioglitazone below eGFR of 60, it is preferable to avoid it. So now let us look at OADs and CKD. Glipizide, no dose adjustment. Glimepiride, use the lowest possible dose. Gliclazide, no dose adjustment. Alpha glucosidase inhibitors, people have a myth that you can use them in high creatinine. Above 2, you should be cautious. Prescribing information clearly tells us that you need to use it with caution. Ripaglinide, no dose adjustment, avoid netaglinide. What about gliptins? We all know that all the gliptins can be used. Only you need to do dose modulation with sitagliptin, vildagliptin and saxagliptin, and linagliptin is not excreted. So if you look at what can you use in CKD, there is a very nice graph which has been given as a clinical practice guideline with patients with diabetes and CKD, and Canadian guidelines have shown very nicely how to use these agents. There is data to show, robust data to show that 25 and 50 milligrams of sitagliptin can be used in moderate to severe CKD. Sitagliptin is the only gliptin which has data in dialysis, head-to-head avoiding hypoglycemia, and ESRD on dialysis, there is a lower incidence of symptomatic and severe hypoglycemia. But there is something more which has come up with the gliptin story now. Sitagliptin showed in a very elegant study on renal ischemic reperfusion that it decreased apoptosis and protected against renal ischemic reperfusion damage. You can see here diabetic kidney tissue, diabetic with ischemic reperfusion, and with sitagliptin clearing it out. There is another new diabetes which has come up. We are seeing more and more patients after transplantation. So the whole new entity of new onset diabetes after transplantation called as NODAT, there is data with sitagliptin to show that you can clearly use it in patients with NODAT, new onset diabetes after transplantation. You can see here there is data available, published, and very clearly it does not cause weight gain and it has very robust A1C and fasting impact. There is good data to show, I am almost done, to show that sitagliptin reduces albuminuria without lowering eGFR. So summing up, from the endocrine perspective, use agents where they don't cause hypoglycemia, they don't cause weight gain, they reduce beta cell stress. Try to look at liver, try to look at safety profile. From the CV standpoint, one has to be very cautious. We have to look at CV outcome trials. We need to have neutral outcomes or positive outcomes. We don't have agents with positive outcomes till date. The CV story is still unfolding. There are caveats for agents with CV like glitazones which may unmask cardiac failure. We do have an indirect signal of hospitalizations of heart failure coming up, but we need to be still cautious. Data in animal data looks very attractive. Outcome data is awaited. From the CKD standpoint, we have seen that here probably gliptins have a clear place which might benefit patients. So if you look at from the patient's perspective, patients need drugs which are effective, easy to use, safe, tolerable and affordable. If you look at from the efficacy standpoint, we need to address drugs which will attack insulin resistance, beta cells, lipid lowering, cardioprotective and probably weight neutral or weight loss. From the physician's perspective, we are looking at patient's health and outcomes, good efficacy, sustained over a period of time, a robust glucose control, and have non-glycemic pleiotropic benefits apart from safety. Thank you for a patient hearing.
Shashank, thank you. We'll have to move on.
Apologies for we could not be able to take up the panel discussion due to time constraint. So we thank everyone, each and everyone.